Good morning, good afternoon, everyone. Thanks for joining us today for today's webinar. We will start shortly. I'd like to remind everyone to please close your microphones in order to minimize background noise. Simultaneous translation is available in English and Spanish. To activate translation, please click on the globe icon on the bottom of the screen and choose your preferred language. Thank you again for your participation. The webinar is about to begin. I'll pass the floor to Dr. Ansam Hennis.
Welcome all and greetings. I'm Anselm Hennis, and I'm the Director of the Department of Non-Communicable Disease and Mental Health at the Pan American Health Organization. It gives me great pleasure to welcome you to this webinar on universal health coverage and sustainable financing for mental health, facing the COVID-19 pandemic and building back better. As the COVID-19 pandemic continues to disproportionately impact the region of the Americas, we're seeing increasing evidence of its profound impact on mental health. People are suffering from anxiety and depression as a result of joblessness and financial insecurity, working from home, sometimes with school-aged children in the household, the inability to gather and socialize, physical separation from loved ones and friends, in addition to coping with the loss of loved ones. There's also the challenge of misinformation in the infodemic we are all experiencing. The COVID-19 pandemic is also inordinately affecting specific groups, including healthcare and frontline workers, children and adolescents, people with pre-existing mental health conditions, and ethnic minorities and indigenous peoples, and those in precarious economic situations, among others. The pandemic has magnified underlying situations of vulnerability or inequity that endanger the mental health and well-being of such groups even before the pandemic. Available data show that the adverse mental health consequences have in fact persisted or even worsened as the pandemic has continued. While the long-term mental health implications of the pandemic remain to be seen, it is likely that we will experience the after effects for generations to come. The need for mental health services has grown, but countries have been seriously challenged in responding to these increased needs. Services for mental, neurological, and substance use disorders have now been identified as the most disrupted program areas, with 60% of countries in the Americas reporting disruptions to these services this year. Countries are, however, generally not allocating the necessary resources to mental health during this pandemic. This is consistent, unfortunately, with a long history of inadequate funding for mental health. Prior to the pandemic, the average public expenditure for mental health in this region was only around 2% of total government health spending, and an average of 60% of this funding has been allocated to psychiatric hospitals. If we are to fully recover from this pandemic and mitigate future emergencies, we must build back better mental health systems which are patient-centered, community-based, staffed with trained healthcare professionals, and adequately financed as we progress towards universal health coverage. Today's webinar will discuss the case for scaling up mental health care and financing in the region of the Americas during the current pandemic and in the post-pandemic period. It will also highlight country experiences and lessons learned in financing mental health. It is my sincere pleasure to welcome Dr. Alejandra Acuña Navarro, Vice Minister of Health of the Ministry of Health of Costa Rica, and from the Ministry of Health of Guyana, Dr. Nadia Liu, Director of Disease Control, and Dr. Util Thomas, Director of the Mental Health Unit. Dr. Daniel Vigo, Assistant Professor of the Department of Psychiatry at the University of British Columbia, will also be a presenter. I want to recognize and thank our distinguished speakers, as well as our participants, for being part of this important discussion today. Now I hand over to Dr. Renato Oliveira e Sousa, Unit Chief of the Mental Health and Substance Use Unit, who will be our moderator today. So over to you, Dr. Renato.
Thank you very much, Dr. Hennis. We will now hear from our presenters. We will have a designated time for questions following the final presentation. In the meantime, please use the questions and answers function that you have here in Zoom or the chat box, so you can submit your questions. And without further ado, it's an honor to introduce Dr. Daniel Vigo, Assistant Professor of the Department of Psychiatry at the University of British Columbia. Dr. Vigo was having some internet connection problems, so he has shared his presentation with us. We will open his presentation, but he's going to be with us and he will be around in case there will be questions and answers, but not to have problems with connections. We will put his presentation now. Thank you.
Good morning. I'm Daniel Vigo. I'm a psychiatrist and faculty in the University of British Columbia. Today we're going to talk about disease burden and investments in mental health in the Americas. First, we're going to talk about how the disease burden due to mental health is distributed. Then we're going to describe the disproportion of the imbalance between the disease burden and expenditures in mental health. We're also going to talk about effective coverage for major depressive disorder. And then we're going to say a little bit about how COVID impacted all of this. So first, we're going to talk about the distribution of the disease burden. The disease burden as measured by disability adjusted life years, or DALYs, which are a summary measure of morbidity and mortality that we use to capture, just with one graph, the overall disease burden in a country. We're going to see we're seeing here the non-communicable diseases in blue, and again we have non-communicable diseases, and in lighter blue the mental health related disorders. Then we have infectious and maternal and child disorders and injuries. And as you can see, about 60% of the burden is due to non-communicable diseases other than mental health conditions, about 20% is due to mental health conditions, and then about 12 infectious and mother and child disorders, and then about 10% due to injuries. So the vast majority is due to non-communicables, and mental health related conditions are the largest among those non-communicables. Now we're going to take more of a life course perspective. That was
I am sorry, this is the interpreter. We lost connection. We have no audio. This is the interpreter. We cannot hear.
Yeah, we have a problem with the audio.
Yes, sir.
Okay, can you hear me?
burden is due to mental health related.
Oh, now, yeah.
By far, largest share of the disease burden, mortality and morbidity affecting the working age population, followed closely by then in Canada, it is neoplasms, cancers, and then cardiovascular disorders, and so on and so forth. And you can see communicables are a small fraction here. Where if we go to a country like Argentina, we see a bit more of the burden of infectious diseases, maternal and child health related disorders, but again, not so much. We do see a large increase in injuries due to accidents, violence, and the burden, the mental health related burden reaches about 40% for people in the working years and stay almost above a fourth or a fifth of the total burden throughout the the adult lifetime, and then gets displaced by the cardiovascular disease burden here. If we look at Mexico, for example, we see that the profile is significantly different. We see the huge burden of violence and injuries in the young, but still we see that mental disorders in Mexico for young people, for working people, are still above a fourth, and also about almost a third at some points of the total disease burden. And then it's followed by diabetes and kidney disorders, which are have a huge burden in Mexico. Then, for example, if we go to Haiti, which is a very low income country, as compared to the others, we see that still the majority of the burden is due to infections, maternal and child disorders, and this affects not only youth and women, but also men, and in dramatic way that leads to the burden being almost half due to these conditions. Still, mental health disorders for the young accrue about between a fourth and a fifth of the total disease burden. But as you can see the different profiles in each country, and you can try to make some decisions when you allocate your funds. Now we're going to talk about how to look within mental disorders. This stacked area chart is different than the previous one in that we ignore all the rest of the burden. The chronic non-communicables are not here, infections are not here, injuries are not here. This is only the mental health related burden, 100% across the lifetime. And again, just to focus on one group, if we look at young people here in Canada are affected almost 50% by what I call the high prevalence common conditions: depression, anxiety, self-harm, and painful syndromes, somatic symptom disorder with prominent pain. But also in Canada, 20 to 30% of the burden due to substance use. In this case, the light brown shows the impact of the opioid epidemic in Canada. And then we have, of course, in the older ages, the neurocognitive disorders due to Alzheimer's and autism in the young. Similar profile, but even larger share of the burden due to the high prevalence conditions: depression, anxiety in children and adolescents, very, very large here, and then also very large self-harm and suicide, and then the chronic painful conditions, not so much the substance use disorders in Argentina, but yes, the alcohol use disorders. The rest of the profile is similar. Then we go to Mexico, another shift for children, epilepsy displacing autism-related disorders as the largest source of burden for the young. We keep neurocognitive disorders, then the huge role of alcohol use disorders in Mexico, and then a large role also for the common mental disorders. In the three countries, the what we call severe mental disorders, schizophrenia, and bipolar disorder have about a 10% of the burden throughout the working years. So now we're going to talk about, well, we've said this is in general about 20% of the total burden in the region. In some regions for the young, more than 50% of the total burden. Well, what does the country investment look like? What this graph shows is the correlation between the investment by the government in mental health and the need in mental health. And so here on the x-axis we have the GDP, the gross domestic product, as a proxy for a country's productivity and income level. And here we have the imbalance between the efficiently allocated spending and the for mental health. What this means is that the WHO says that the spending for health conditions should be proportional to their level of need, and if we said that that the need for mental health in the region is about 20% of the burden, we could expect that a significant investment of around 20% could be expected. This is of course not the case, and so what we're measuring here is the imbalance, that says how disproportionate is the investment to the burden, meaning how many times does the burden go over the actual investment. And if we can see here in this bar chart here, we can see in the case of Canada and the US, which have the lower imbalance, the burden is 3 times the proportion of the spending. So the burden, let's say if the burden is 20% or 21%, then the investment would be 7% of GDP, et cetera, et cetera, et cetera. And so in the case of the highest burden is 435, the burden, and it's a median of around 31%. And if you see here, the imbalance is inversely correlated with government income, with a country's output. And you can see how Canada and the US have the lowest imbalance, meaning that they spend more money, and the money they spend in the community instead of in tertiary hospitals. And you see Argentina here, for example, Mexico here, you see Brazil here, different degrees of imbalance, and to the poorest countries have the highest imbalance, compounding the neglect of mental health conditions. What does this result in? Well, it results in specific profiles of coverage. This uses a conceptual framework developed by Tanahashi at WHO, and that was published last year in an article called Towards Measuring Effective Treatment Coverage. We're going to focus on this part here, which is the actual coverage. You see, this is the people in need, let's say people with major depressive disorder, and there's some available services which may or may not be accessible and acceptable, and you see we lose people at every step. Some of them get contact coverage ultimately, they get to the health system for that condition, and then we do input adjusted. Well, are they getting the right medication? Are they getting the right psychotherapist? Process adjusted, are they getting enough sessions? User adjusted, is the user complying with the indication, and so on and so forth. So this is that picture in the Americas, and what we can see is that overall here, 37% of people get contact coverage. People with major depressive disorder, 37% are getting some sort of service, and only 11% are getting the adequate service, effective coverage. And this varies. For example, in the United States, 53% of people get any coverage, and 18% of people get contact coverage. And if we go to here in Colombia, we have 19% of people get in need, get any coverage, and 1% get effective coverage. And then we have all sorts of distributions in between that countries can look at and see what's the problem or where are the extra resources. But basically the message here is that the imbalance between low and high income countries in the Americas is very high. High income countries have 3 times the effective coverage of low-income countries, which is larger than globally. And by the way, these are only those countries of the Americas that we were able to study. And this is just for us to know that the likelihood of having effective coverage for a patient is influenced by whether they're relatively young, middle-aged actually, they have high education, and have some form of extra insurance. Those have a 1.6 increased likelihood of getting effective coverage. So in this context, the effect of COVID. Well, the effect of COVID will depend on 3 things. There are measures of physical distancing, which allowed the countries to restrict viral circulation or fail to do so, and therefore death and disability. There's the shutdown of the economy, which happened in most countries, either willingly or unwillingly, but with different levels of intensity. And then the resources that the countries were able to pour into the population so as to avoid impoverishment, loss of jobs, loss of productivity, and then the vaccine. How quick is the rollout? How effective it is, etc. So the combination of that will give us the mental health related picture. And to some extent, we can expect that that will change in high-income countries versus low-income countries, and it will change in countries with an organized response and a disorganized public health response. In high-income countries, what we're seeing already is that there's an increase in the help-seeking behavior after COVID across the board. On the left, you can see a survival curve that tells you that the red curve there is post-COVID dementia, which you see is much higher than for other respiratory tract infections. And on the right, mood, anxiety, psychotic disorders all bunched together. Again, more people seeking help for those conditions than people with other respiratory infections after exposure. So we can expect an increased help-seeking behavior. Now, that help-seeking behavior, we need to understand it a little bit better. This is another study that shows that, in fact, in high-income countries, 90% of the population does pretty well. It's the three curves at the bottom there. Most do well right off the bat, and some do a little bit worse initially and then get better. The question are the ones that do worse, which are the two lines on the top. This is a life and class analysis study, but I just want to show that there's about 10% of people that do worse, and those are the ones that have pre-existing mental and physical conditions. So those are the ones that will need our specific help. And this is, we're talking about high-income countries that have poured a lot of money into supporting the general population. And we need to understand that the burden of COVID is a burden on the older populations. 95% of the deaths occur 65 years and older. And so prioritizing vaccinations, protecting the old population, and at the same time, if the economy is shut, taking care of the young people, not to be impoverished, lose their job, etc. So some countries have been able to do that, some countries have not been able to do that. In the case of Canada, we can expect the impact of infections to significantly increase because of COVID. Increase will be focused exactly on the older population, but the rest of the picture of the non-communicable diseases will not be significantly altered. Things will kind of go back to where they were once the vaccine rollout is effective. Now, what will happen in the rest of the Americas? We don't have data to do that kind of estimation, but what we know is that in high-income countries, well, in general, in both types of countries, we have different groups of people affected differently by COVID. General population and essential workers, they will be subjected to stress-related disorders and trauma, depending on whether they got the virus, depending on whether they were at the front lines, etc. People with pre-existing conditions, they will suffer worsening conditions because of the disruption of services. And in the case of high-income countries, well, the stresses, the initial stresses, but then go back to normal. And people who are infected by COVID, we're seeing a new rare forms of psychosis and other neurocognitive disorders that seem to stem from COVID that we understand poorly, but it's a very small fraction of the population. So in summary, we can expect an initial worsening, but then back to some version of normal in terms of the stress-related disorders and trauma in high-income countries. Common mental disorders, again, they may increase for a while, but then they'll come back to normal. Those with pre-existing conditions may have an increase in severity that is more long-lasting. Unfortunately, those with severe conditions, such as neurocognitive disorders due to Alzheimer's, have been dying because of the impact on older people. So there will be a diminished prevalence because of increased mortality, and then we will have an increased severity of the cases that survive. And with respect to people infected by COVID, we'll see this very severe and increase in numbers cases. Now, in low and middle income countries, the picture will be much more dire because we will not see, unfortunately, the population going back to normal because of the destruction of their livelihoods in the US, in Canada, in other places in Europe. People, when the economy was in lockdown, received a check that guaranteed their livelihoods, their children's livelihoods, etc. Whereas in our countries, unfortunately, this was not possible because of the lack of resources or because of other reasons. So we can expect an increase in conditions that respond to worsening of social determinants of health, such as poverty, marginalization, loss of productivity. And so we can expect an increase in depression, suicide, anxiety, etc. Then we have people with pre-existing conditions. Again, it will all depend on how well can the system reabsorb them into care after the complete disruption of COVID. But the situation will be dire, particularly for the older folks who have also been dying very, very in a widespread manner. And the same with the new neuropsychiatric disorders, which will be severe and difficult to treat. So the picture is very, very complex for low and middle income countries, particularly if they don't succeed in rapidly scaling up vaccination efforts. At this point, there's not much else that can be done because of the spread of the virus unchecked, producing new variants, etc. So disease burden is about a fifth of total burden in the Americas and more than 50% of the burden in young people in high-income countries. It is 32 times the allocated budget, and this imbalance is directly or inversely correlated with income. The coverage varies between 1 or 2% and 18%, and it has to do with the income level of the country, and the contact coverage, same. It oscillates between 19 and 53. The gap in effective coverage is 3 times high-income countries to low-income countries, whereas in globally it's more like twice, so it's even more unequal. And this gap is determined by age, education, and availability of good medical insurance. And unfortunately, in countries where COVID-19 was not adequately controlled, where there was not sufficient distribution of resources to mitigate economic lockdowns, and where vaccination rollouts are not swift, we can expect enormous increases in the help-seeking behaviors and demand for services, which, unlike what will happen in high-income countries, will not come back to a level of statu quo ante because of the destruction of the economy and the pervasive effect of the economic lockdowns without sufficient help. Thanks. I'll be happy to take questions if I'm able to maintain my internet connection. And if not, my email is daniel.vigo@ubc.ca. Thanks.
Thank you very much, Dr. Vigo. That's really a fascinating presentation that really highlights inequities in health, inequities in mental health, aggravated by COVID-19, and really an excellent overview of mental health financing in the region of the Americas, which really sets the stage for our country case studies. So first we will hear from Costa Rica. It's my pleasure to present Dr. Alejandra Acuña Navarro, Vice Minister of Health for the Ministry of Health of Costa Rica. Dr. Acuña Navarro, please go ahead.
Muy buenos días a todos y a todas. Un placer estar aquí con ustedes.
Good morning, ladies and gentlemen. Thank you very much for having me here. I'm going to share the presentation with you that I have. Well, I was asked to cover 3 key elements for the impact of mental health on mental health in Costa Rica, actions during the pandemic, and financial resources devoted in the country to support mental health. And I think, again, the third item is the key discussion point during this event. So we have been working with other key stakeholders, including the national universities, and I'm going to highlight the situation where 61% of the population of Costa Rica reported in October of last year that they were suffering from symptoms of depression. 43.7% also showed some symptoms associated with anxiety, in fact, severe anxiety. So looking at the socioeconomic vulnerabilities, as we just saw in the previous presentation, that has been faced by diverse communities as a result of the pandemic, we're seeing that on average, families were receiving less than $760 and a year. And of course, a lot of this is associated with the shutdown of businesses, lockdowns during the pandemic. All of that had also a major impact on the mental health of many of our citizens. Now, if we look at job stability, which was another key characteristic, about 70% of the population that were without jobs by COVID had, as a result of COVID-19, showed signs of depression. And 64% of them that had only part-time jobs showed the same characteristics. Now, research has also determined that the lower the level of education, the higher the percentage of people that presented characteristics and signs of depression, with the highest level for those that had not finished or only finished secondary school, followed by those with secondary school or non-university backgrounds. So we know that these are populations that are highly vulnerable. And up until now, we wanted, of course, to measure these communities. So we had a survey conducted, the second survey that was done to with the LGBTQ community. And many of the people that we surveyed in Costa Rica with this survey showed that they had seen changes in, for example, their sleeping patterns, signs of depression as well. They had symptoms. 46% had symptoms of anxiety, and 17% even felt feelings of suicide. And not only among these communities, we also have other data. And because of the time constraints, I'm not going to get into a lot of detail, but we know among young people, children and adolescents, because they had their school schedule suspended, and many of them, because they had to do virtual classes, also showed signs of emotional problems. Again, children, adolescents, and some that were not used to the internet, and so they were highly impacted as well. And human relations in the process and schools were completely impacted and affected. So it's important to see exactly how psychological support services are so essential. So we have the 911 number for psychological counseling and support. And we have, for example, not just permanent, but also volunteers. And we saw 9,364 calls were responded to. Now, some people from larger countries might think that this is not a significant number, but this is highly significant for us, for a country our size. Here, we had in one district 17 calls per day, which means that we have more and more people in our community that require support, that require counseling, that need to be listened to. So it's important that this gave us an idea of the magnitude of the problem in the country. Now, what measures have we adopted as a result of the information gleaned? This is the emergency resolution that was issued, a decree, and this led to the creation of an operations committee that included a health council or board, where we have one board that works with mental health and support in order to address and provide healthcare services, also maintain communications infrastructure, and work with the local communities. This board is actually subdivided into several other agencies where we work with the Ministry of Health. We maintain links with other ministries. We also have the technical operations division, where we provide additional assistance and support. So we maintain, for example, and provide information packages to raise an awareness among the community at large, as well as specific priority groups. Also, we believe that it is important to have a key focus working with all of the stakeholders, where, for example, we developed technical criteria for inclusion, as well as respecting the human rights and diversity and equal treatment of men and women in all of our campaigns, our awareness raising campaigns, and official statements and releases. We also updated and developed specific guidelines for critical situations and in emergency interagency responses. That was crucial. And actually, we have an interagency committee that was devoted to this, as well as the development of guidelines and protocols, working, for example, with the general guidelines and based on community communications, looking at the psychological and psychosocial communication and support that we can provide, also working with emergency municipal committees, especially during the pandemic, developing general guidelines for providing services for women who are subject to violence, as well as domestic abuse, general guidelines, working with developing psychosocial communication and support, and protocols were also established. And here, our advice in dealing with mental health and psychosocial support to those affected by COVID-19 throughout the country was also a priority, compiling institutional standards documents in order to provide preventive measures as well as medical treatment for people suffering from COVID. Also developing follow-up reports provided by institutions that address services to the population affected by COVID-19, and also interagency coordination measures, working and creating a virtual system where we also address the needs of children and adolescents affected. So these were measures that we used in order to have outreach with the local communities. Interagency coordination includes the following entities that we see at the bottom, providing support also for the elderly in order to assure that we can prevent the spread of COVID among these communities, working addressing the needs of vulnerable groups. Therefore, a follow-up was done in terms of the formulation of guidelines for example, informal shanty towns, and in order to include lower income communities as well. So this is our list of emergency services, our 911. All of these agencies participate in the response and not just in the area of mental health, but also all medical services. And through these, we have, for example, the INAMU, which is a National Women's Institute that provides support in cases of domestic violence, and also helping adolescents who may be victims of domestic violence. Also, we have the National Psychiatric Hospitals. We have suicide hotlines and we also have the psychological counseling hotline. We have the College of Psychology that has staff that is also providing support. We've also received some support from UNICEF that addresses the needs of children, boys and girls, and adolescents. And we also have the School of Professionals in Psychology, DAP, working in unison with the Ministry of Health of Costa Rica. Also, several research projects were undertaken, looking at, for example, mental health and relations with the surrounding communities during times of the COVID-19 pandemic. The impact of mental health on older adults during the COVID-19 health emergency in Costa Rica and Spain. Also, the psychosocial effects of the pandemic on healthcare staff and healthcare workers. So we developed a work plan. It's important to also mention that we have specific standards, technical standards in the providing of support, psychological and psychosocial services. During the pandemic, we here in Costa Rica have also just developed programs with local committees that are providing psychological counseling and support services to their local communities, developing instruments associated with the recovery plans as well as the dissemination of these organizations' activities. So many of the processes, emergency processes, and environmental and healthcare problems also generate more mental health issues, especially some of the environmental problems, such as disasters, for example. We've also seen a strengthening of the management of the interagency entities. We have regional entities, also local providers of support. Currently, we are strengthening the capacities of these intersectoral entities and are providing a great deal of support at the national level. We also have specific strategies for activities that target vulnerable areas. We have courses, for example. We have communications, strategic communication, working on healthcare. Now, looking at the financial situation, the OECD has recently launched a mental health program, and they believe that mental health issues have created costs, economic costs, that are equivalent to more than 4.2% of GDP. And some of these are direct costs relating to treatments, but 1/3 has to do with reduction in employment levels as well as productivity. According to the report, we need to do the following. First of all, in Costa Rica, we see that we have an imbalance, an economic imbalance, also in terms of the coverage area, as well as investments. There are three key elements that we consider to be essential. Working with the Ministry of Health and working with the Ministry of Finance and the legislative branch, a specific budget was approved to address these challenges. There is legislation that authorizes and this is the authorization for the change and modification in the social protections and distribution of income from national lotteries. 3% of these resources will be devoted for preventive health programs. This is essential because when we invest in mental health, we're always focused on treating mental health, but now we also will have resources devoted to preventive measures as well. And thanks to legislation that was passed in 2018, through the Social Medical Technical Assistance Board, 10% will be used to fund programs and activities that promote mental health prevention measures. So as a result of the pandemic, we are focused also on developing regional programs, providing support for the local communities, working with the Ministry of Health, assisting, for example, the municipal governments, including such activities as sporting events and recreational, expanding recreational activities as well. And of course, the budget for these social programs will be providing a direct support for hospitals. And here we have, you have the comprehensive first primary health support. But I think one of the major challenges that we have right now as a country is to also, in the national counts, we need to include mental health priorities as well, and not just overall health support services. So PAHO, I think, has helped to facilitate that, and I think it's necessary that we encompass this. Also to exactly see what are the investments. And here we see with the pandemic that we have intersectoral efforts implemented, and we see how each one of the institutions have expended, but we need to measure exactly what contributions each one of the agencies have contributed in the sectors as well. So these are the resources that have already been provided by the IMF. Here we have additional resources. And the good news is that we have 5 activities that are included in the funds proposed package that includes development and implementation of communication and strategies, community mobilization, and promoting and preventing healthcare problems. And during the pandemic, in vulnerable and key communities, also hiring temporary personnel for providing first-line psychological support, and also community strategies, and supporting the 1-800 hotline for addressing the needs of women in particular with specific challenges that they're facing during the pandemic, in addition to earmarking some resources for research and promoting strategies to reduce the problems of substance abuse. during the pandemic, including the use of alcohol that has contributed to more challenges during the pandemic. Well, that's basically everything that I had to share. There's a lot that we need to continue to support, and we need to make sure that the budget resources are up to the challenges that we're facing, as well as that intersectoral engagement, which is so important, that there are stakeholders who work at the local levels that have provided health care resources, but we need to measure exactly what some of these contributions have been to get an accurate picture of what's actually going on. Thank you very much.
Thank you very much. Thank you, Dr. Acuña Navarro, for really sharing with us the important work that Costa Rica is doing to meet the mental health needs of the population during the COVID pandemic, especially highlighting the focus on human rights, diversity, gender perspective, and equity. Also important that you emphasize the work with other departments as education, for example, and what you mentioned as the interinstitutional or intersectoral coordination. The whole of government approach, as we say, that is so much needed in mental health. Thanks also for bringing to us the financial mechanisms that you have in place in Costa Rica, and bringing the emphasis on some financial mechanisms via legal regulations, and also for bringing to us the importance of the focus on substance use as an area that is very important during the pandemic. Thank you again very much. Now we will hear about the experience of Guyana. I'm honored to present Dr. Nadia Liu, Director of Disease Control, and Dr. Util Thomas, Director of the Mental Health Unit for the Ministry of Health of Guyana. The floor is yours.
Good morning, everybody. All protocols observed. Thank you for having me. It's a pleasure indeed. So I'm going to go right into my presentation. So in this presentation, I will be speaking about the mental health impact of COVID-19 in Guyana, discussing what needs to be scaled up in terms of mental health in Guyana and our funding mechanisms. So let me begin by saying that the responsibilities of our Let me begin by saying that the responsibilities of all governments is to provide financial protection for all its citizens so that persons do not become destitute as a result of taking care of their health needs. And I want to say that the government of Guyana is attempting to do that because the cost for healthcare in Guyana is entirely free. So in Guyana, our minimum wage is $70,000 per month. This is an average of $11 per day. And there's an unemployment rate in 2020 of 12.8% and a youth employment rate of 30.1%. The figures for the unemployment rate in 2021 was not available, but the youth unemployment rate was almost the same. The poverty line is considered to be $5.50 US. And according to the World Bank, Guyana is one of the poorest countries in South America, with a good portion of the population living on less than $5.50 US per day. We have a population of 746,955 persons, and we have 10 administrative regions, in which the most populated was Region 4 and Region 6. So we got our first case of COVID-19 on the 11th of March 2020. And this is an excerpt from the speech of the then President, Mr. David Granger, where he said, "It is my sad duty to announce that Guyana confirmed its first case of imported COVID-19 on Wednesday, 11th of March. The patient has been identified as a 52-year-old Guyanese female who came from the United States of America, which has reported cases of COVID-19. That patient died on the 11th of March. So this is our current COVID-19 situation, and this dashboard shows that as of July 23rd, there were 22,090 cases of confirmed COVID-19 and 523 deaths. The number of persons accessing services in 2018 was 5,083. So there was a gradual increase from 2016 to 2018 of persons accessing the services for mental health conditions. In 2019, the data was not collected because there was problems with funding. But as of 2021, from January 1 to May 31st, 2,156 persons have accessed the mental health services, which indicates that by the end of 2021, there should be approximately 5,000 persons that will be accessing the mental health services. So there is no evidence that increased number of persons are trying to access mental health psychiatric services. And this is mainly due to disruption of health services due to the COVID-19 pandemic, reduced working hours, lockdown measures producing challenges in transportation and access to services, and fear of visiting health facilities and becoming infected with COVID-19. So in July of 2020, there was a survey, a CAP survey, knowledge, attitudes, and practices on the mental wellness of adults and adolescents in the COVID-19 pandemic. And in this survey, a total of 3,363 persons were interviewed, and they were a mixture of adults and adolescents. And it was found that the major stressors were concerns about the risk of being exposed, taking care of personal and family needs, adapting to different lifestyle, and uncertainty about the future. Those were the major stressors. But however, most persons felt that the risk of being exposed to the virus was a major stressor. Most persons felt that their life was different, but they were managing okay. So that means that even though they were exposed to the stresses, most persons were coping. And to cope with the COVID-19 pandemic, they were engaging in activities such as looking for safe ways to offer social support to others, especially if they were showing signs of stress such as depression and anxiety. They were connecting with others through phone calls, emails, text messages, mailing letters or cards, video chatting on social media. They were reminding themselves that everyone is in an unusual situation with limited resources and taking breaks from watching, reading, or listening to news stories, including social media. They were also connecting with others. They were talking to people about their concerns, how they were feeling, and how the COVID-19 pandemic were affecting them, and reminding themselves that they had a crucial role in fighting the pandemic, among other measures. However, um, lots of persons were helping each other, and so they were getting help from family and friends, from the community or the church, and very few persons were engaged in NGOs or the governmental department. So in response to our COVID-19 pandemic, there was a strong collaboration with PAHO, WHO, and our collaboration involved air communication. Our program was It's Okay Not to Be Okay. That was a radio program, and the main objective was to build capacity of the citizens to cope with COVID-19. It aired for 7 months from May to November 2020. We also collaborated with virtual training of frontline healthcare workers to manage mental health complaints in patients affected by COVID-19. There was the MH gap training of healthcare workers. There was lots of training for psychological first aid for healthcare workers, the launching of a 24/7 counseling service. And I want to say here that a lot of the funding was from PAHO WHO. Our main challenge is human resources, specifically for mental health. So we, in the future, after the pandemic, we would like to see psychiatrists in each of the hospitals in the 10 administrative regions. Our current number of psychiatrists is currently 10 for 10 psychiatrists. There are psychiatrists in 4 of the 10 administrative regions. As a long-term solution to that issue, there is the Masters of Psychiatry program, which graduates an average of 2 psychiatrists, which is a collaboration of the University of Guyana and McMaster University. And it is funded by the government of Guyana. Also, as a long-term solution, we've launched the bachelor's degree in mental health nursing, which is a collaboration with the University of Guyana and St. Joseph's University. The tuition is 300,000 Guyana dollars, and that is accessed through scholarships, student loans, or out-of-pocket funding. There are currently no mental health nurses in Guyana. And it is the hope that we will gradually be able to staff our more than 300 healthcare facilities with mental health nurses in the near future. As a long-term solution also, we are hoping to start our psychiatric nurse practitioners program. There are no psychiatric nurse practitioners, and that will be a master's at a master's degree level at the University of Guyana. The funding will also be student loans, scholarship, and out-of-pocket funding. The University of Guyana has a diploma in psychology currently existing. That degree in psychology was due since 2019, and we hope to have that started soon. That too will be financed through student loans, out-of-pocket payments, and scholarships. There's a diploma in social work program, the bachelor's in social work program, and the master's in social work program at the University of Guyana, financed by the government of Guyana, and can also be accessed through loan scholarships and out-of-pocket funding. And the challenge there is that positions need to create it in the health facilities in order to access the very important skills of the social workers. We have no occupational therapists. Funding has to be assured for that, and for training of occupational therapists, and that's a possible University of Guyana program. The curriculum needs to be developed. And we are currently in a collaboration with PAHO, WHO, to have 40 addiction specialists trained. The funding is going to be entirely the government of Guyana. We've recently launched our Safe Space 24/7 counseling service. This was launched in response to the COVID-19 pandemic, and virtual counseling was done, and it is a government of Guyana funded project. There's lots of needs for capacity building and updating of curriculums for such as a general nursing curriculum, teachers curriculum, police, soldiers, and other military workers curriculum. So in the future, we need more funding for mental health, and funding can come from tax reform, specifically new tax measures on alcohol, which can, a contribution from which can go to funding for mental health. And we also need a lot of reform of our national insurance scheme so that they do more preventative work instead of just paying out benefits and claims. The government of Guyana has been, over the years, continually increasing the amount allocated for health. As we can see here, the health budget has increased from year to year since 2016. And in addition to that, they have been allocating more and more funding for mental health. The funding that has been allocated in 2021 is adequate for the COVID response and all that needs to be done for mental health currently. So that's, thank you. Over.
Thank you very much, Dr. Thomas, for your presentation on how Guyana is addressing the current mental health situation, and also for sharing with us that even with the challenges, as you explained, especially in terms of resources, via collaborations, the country has been able to scale up and respond. Thanks also for sharing with us the prospect of new taxation on alcohol to increase resources for mental health. It's very good to know that. We will now have some time for questions. If you have not yet had the opportunity to do so, to please put your questions on the question and answers or on the chat box. and we will submit your questions to the presenters. Let me go through some of the questions that we have already received here. I don't know if Danielle has been able to join us. We have a question for Dr. Daniel Vigo. Claudia Peseto is asking if you could elaborate, Daniel, on how health spending on mental health has been measured in your models. I don't know if you're
could you repeat? Yeah, could you repeat the question, please?
Yeah, for sure. Claudia has asked you, Daniel, if you could elaborate more on how the health spending on mental health was measured in the models that you presented.
Yes, thanks. So that study was using PAHO data, data from the Atlas, data from the AIMS instrument, from all of the different tools that WHO and PAHO have for collecting data from countries. So it is self-reported data by country. Did you hear that?
Yes, yeah, no, that's very clear. Thank you. Thank you, Daniel. There is okay, let me go with another question here for Dr. Acuña Navarro from Costa Rica. The question is, what are some of the main challenges you have encountered in bringing additional financial resources to mental health in your country? And what have you done to overcome those challenges of bringing financial resources to mental health during the pandemic?
I believe that here we have an important element that I may have not been clear when I mentioned it. Costa Rica has already a national budget that has been allocated for mental health, and this is the Social Security Service of Costa Rica that is allocating resources expressly, and the country then saw the need to strengthen those resources also by allowing more resources for the staff working in the area of mental health. We have, for example, teams of psychologists, psychiatrists who are already among the service providers. And also what we did is to work with resources. We need to remember that due to the pandemic, many of the services were no longer provided, and this fund is being used. So we have the remaining budget from these units that are being used. So there was a reduction, but at the same time, there were already resources that had been allocated. So we mobilized those resources through local efforts and regional efforts to be able to properly address the needs. And once again, this is a multi-sectorial approach through various bodies. The municipalities were already implementing these initiatives for mental health, and also the National Institute of Women with their own resources. PAHO also provided us resources throughout the processes that we developed, in particular to have proper communication with the vulnerable population. So there was a very significant support that came from PAHO through the technical aspects and also the financial support to be able to take this at the level of the community. So this multi-sectorial approach and the social determinants of health were the ones that allowed us to have greater mobilization of the resources. They are not completely sufficient. We still have a great deal of resources that need to be devoted to mental health in Costa Rica, and that's the reason why we also resorted to the Global Fund when we heard that they had extra additional resources. We thought this is the right time, this is proper to be able to use these resources. We have a grant and we thought, well, why don't we use this for mental health? But once again, it has to do with having this as a priority within the country and think of mental health as a priority for the country. We need to think of all the mechanisms to have cooperation, intersectoral cooperation, so that we can devote the resources to address mental health problems that we face right now and that we will continue to face with our population. So what have we done? We do not have all of the resources. We would love to have them, but we have, it may seem that we have addressed all of the needs, but that is not the case. And we are having this intersectoral approach to create new policies and policies in other sectors, health and in all of the other areas. So in health, we need also to have the social, include the social determinants of health, and also include the different elements that may contribute to improve our health situation. Thank you.
You really emphasize, I mean, three very important key messages, as you said, like the whole of government approach. So mental health is a concern of everyone. The importance of partnerships, as you have been saying, bringing others to work together on mental health. And what you also have mentioned, possibilities of integrating mental health into other areas like HIV/AIDS, non-communicable diseases. So these are opportunities that we need to grasp to be able to scale up and do more. Thanks for sharing the lessons learned from Costa Rica, which I'm sure they are very useful to other countries also in the region. I have now another question here for Dr. Thomas from Guyana. The question, Dr. Thomas, is a colleague is asking if you have been implementing the MHGAP program in Guyana, and perhaps I can also add something to the question. If you could be sharing how has been the experience of implementing and scaling up MHGAP in Guyana.
Yes, we have implemented the MHGAP training in Guyana. We implemented that since in 2017, and we have so far trained from 2017 to 2021, 430 doctors and nurses. However, so these doctors and nurses are located at 98 facilities across the country. However, we have more than 300 healthcare facilities. We have about 311 healthcare facilities in Guyana. And of the 311 healthcare facilities, 98 facilities have trained persons. However, the implementation has varied because some persons are just more proactive than some. And we have had challenges with the medication. Previously, before we started training persons in the MHGAP, the primary healthcare facilities did not carry certain medications. But now, in order for the doctors to practice, they have to have access to these medications. So in Guyana, the health service in the region is controlled by the regional health officer. And some are more aggressive in making sure that these medications get all their primary health care facilities, and some are not so aggressive. So what sometimes happens is that when the primary healthcare doctors who have been trained do not have access to the medications that they would want, they refer these cases instead of treating them. So it's been a mixed response.
Thank you. Thank you very much, Dr. Thomas, for sharing the experience on MHGAP implementation with us. It has been one of the flagships of us in PAHO in working with the countries, trying to develop training, capacity building, and being very close to the countries, especially during the pandemic now, on implementing MHGAP. So the lessons learned, the obstacles, the challenges, it's very important that we know so we can do it better. Danielle, there are two questions here for you, which I think are super relevant. So if you don't mind, I'll ask both at the same time. The first one, Daisy Sanchez is asking you, you mentioned during your presentation the new neuropsychiatric conditions that can be presentations of people affected by COVID. So Daisy is asking if you could elaborate a little bit more on that. What are these conditions? So what has been your experience on that? And the other question, Danielle, which is a fundamental for the region and for the countries that are trying to do more, is what do you believe are the most important pieces of evidence that mental health actors in the government in our region can use to engage the high-level policymakers in advocating for increased financial financing for mental health?
Yes. Those are two very interesting questions. The first one is we've been seeing new cases after people were infected by COVID, cases of new onset psychosis, which are very unlike other forms of psychosis that we know. Most psychosis are, schizophrenia, spectrum disorders tend to start during adolescence or very early adulthood. But we've seen cases of people in the 30s, 40s without any specific previous mental illness that develop psychosis and very specific forms of psychosis with hallucinations, command hallucinations, and so on and so forth. And I think this is not particularly strange, given that COVID does attack the central nervous system. It is a multi-systemic disease. So we will be seeing some of this, but again, it's a very small percentage of people that will develop these disorders. Then we have the long COVID and some strange fatigue syndromes, and then the more stress-related or mood or anxiety-related, but that's more of the common thing. The highly prevalent disorders that in a situation of increased stress, such as COVID, will of course increase. But there's this new thing, which are these strange psychotic disorders. So I think that's what that question was about. And the other one is, how can we convince our dear friends in the Ministry of Economy or Finance that this is a worthwhile investment? I think what I showed in my presentation, which is that in high-income countries, the burden related to mental health, I apologize for the noise, just a second. That in high-income countries, the burden related to mental health in young people is about 50% of the burden, 50% of the whole overall disease burden of, taking into account any form of human illness. That results in an enormous loss of output. And in the case of low and middle income countries, such as most of our countries, this is around 30%, 40%. And so it is a large part of our economic output that is being impaired by untreated mental illness. So I guess that is the best case that one can make. I'm developing now with some colleagues that are also PAHO collaborators, like David Bloom, a model to quantify the whole societal cost of mental illness, including loss of output, caregiver burden, and so on and so forth. We need to keep counting, and we need to count in more innovative, precise ways to convince our colleagues, dear friends at the Ministries of Economy, who speak that language and no other, and for a good reason. And so that is what we need to do.
Great, thank you very much. Thank you, Daniel. I think we have time maybe for one or two more questions before we need to close. I have a question here for Dr. Acuna. The question is, what are the key, based on the experience of Costa Rica, what are the key recommendations you would offer to other countries in the region that are struggling to increase financing for mental health during the COVID pandemic, Dr. Acuna?
Bueno, muy buena pregunta. Creo que muy relacionada.
Very good question. I think it is closely related to the question asked to Daniel and Dr. Thomas. We do need to find national financing mechanisms and have new resources. It could be by means of a tax. And what we use here is a tax on the national lottery system. So we are trying to go beyond the national budget for health. And we're trying to find mechanisms so that from other areas we can grant funding, for example, for physical activity and sports. For example, the Costa Rican Sports and Physical Activity as Institute is devoting resources to health. So we need to think of the determinants. We need to think of the health approach and prevention. We also have funding that comes from the state and the local committees for the youth to create new programs. For example, we're providing financing to municipalities and local committees, local youth committees to generate new projects so we can work with the youth so that they create health-related projects. So I think that this is where we need to start looking at how we can reach out to the various sectors and try to identify taxes that we can levy, for example, on labor, alcohol, and I said the lottery. I said that the national lottery in our case is also providing funds for mental health, but also for shelters, youth shelters, children's shelter, disability funding. So there are some mechanisms that we can review and that are not directly related to the national budget or the service providers. And once again, we need to insist on the fact that we have a plan. We have a plan, a national plan for mental health, and we need to take this plan to the operational stage at the institutional level so that we can have the resources we need. And this is something that will allow us to guarantee the resources we need. It is not easy because it has not been easy. However, with the pandemic, all of the institutions are working on mental health. So we have been able to have each institution provide resources. We're going step by step, but we clearly need to include mental health at the national level to see where the resources are. So I think that this is important, and PAHO's support is key for Costa Rica to carry out that measurement. Because if we have this measurement, we can then help decision makers to determine where and how to invest our resources.
Thank you very much, Dr. Acuna.
We are coming to the end of today's webinar. It's a pity there were more questions, but we need to finalize. I'd really like to extend a big thank you to all of our presenters for their contributions and to everyone who joined us here today. The COVID-19 pandemic has created many new work-related challenges for all of us, and we are really grateful that we were able to take a break from your busy schedules and you could participate. Thank you very much. If we've learned anything from the unprecedented COVID-19 pandemic, it is that we can no longer afford to neglect mental health in our region. Despite the incredibly high rates of morbidity and mortality in the Americas due to mental, neurological, and substance use conditions, we continue to dedicate only a tiny fraction of government health spending to mental health. The number of people suffering from these conditions and their severity in people with pre-existing mental health conditions have only grown and continue to grow since the onset of the pandemic. Existing mental health services have fallen short and failed to bridge the mental health treatment gap that has been widened by the COVID pandemic. But as we have seen here, as we have seen the experiences shared here, we have the power to change this. We know that investing in mental health yields substantial returns, and the COVID-19 pandemic has brought heightened visibility to the issue of mental health. Furthermore, countries in the region have been employing innovative approaches to meet new mental health challenges, as you have also seen here today. So these opportunities must be leveraged to scale up mental health financing now and for the future. As a region, we are facing this mental health crisis together, and collective challenges require collective solutions. So we must continue this important discussion in order to learn from each other's experience and work together to position mental health in the region where it really belongs. So thank you so much again. Have a nice day, and please stay safe. Thank you.